Stigma, discrimination, and limited information on non-communicable diseases is still rife in the Kenyan society. This is evidenced by, among others, the fact that people living with epilepsy are top of the list when it comes to challenges such as lack of job opportunities that face this group.
Greetings, everyone. My name is Dr. Michael Magoha. I'm a consultant neurological surgeon and lecturer at the University of Nairobi in the Department of Surgery. Thank you for the invite to give this talk. The talk I shall be giving today shall be Epilepsy, a Clinical Review and Surgical Options. Before we move forward, when I was invited to give this talk, the first thing I thought was it's almost impossible. It's way too large. A simple procedure like hemispherectomy itself, you could discuss that for about 2 hours. You think about the nuances, the indications, and what to do. So I had to think about this, and I thought about who I was talking to and where we work. And I figured that it has to be as simple, straight to the point, and show us what we need to do so that we can get better. So hopefully you'll find this useful. And if not, you can always let me know. I'll give you my contacts at the end. So, what are we going to go through? We'll go through 4 main parts of this today. We'll have an introduction, which is the things that you most likely know. How we diagnose epilepsy, what we're supposed to do with it. Next, the treatment options, the surgical treatment options. And 4, the most important part for me would be the way forward. What do you do after listening to this so that it's not just an academic exercise? So, the introduction, we're going to define what epilepsy is, the clinical features of seizures. Then we're going to discuss diagnostic tests which are necessary to diagnose epilepsy. Then the surgical treatment options. We need to identify diagnostic surgical treatment options, curative treatment options, and palliative treatment options. And the way forward is you need to have key takeaways and applications that we can use from this talk to move forward. So, introduction. This is most of the stuff that hopefully all of you already know, but we'll keep saying it because once you reinforce, you get better. Now, this is a very nice quote that I like. This is Scott Hamilton. He's a well-known American figure skater. He had secondary epilepsy due to a brain tumor. I must confess, I don't remember what the brain tumor was, but the quote says, "The only disability in life is having a bad attitude." So any of you residents, if you keep on complaining, all you know is that you're giving yourself a disability. But here's the thing about epilepsy as we get back on track. So many people live with epilepsy and we don't know. I think being in a third world country, we tend to associate with a lot of stigma and disability, but there are very many people that you see every day that you don't realize are well-known advocates of epilepsy. Let me give you a couple of examples. One is Prince. Not many people realize that Prince is a well-known epileptic that was well-controlled till his untimely death. Next, for the younger generation, this is Lil Wayne. Lil Wayne is a well-known epileptic that's been under control since birth. Others would be people like Danny Glover. This would be for the older generation. You might know him from movies like Lethal Weapon. And slightly younger, people might not realize that in the movie Matrix, Neo was fighting an epileptic who was Mr. Anderson. So this is just to show you that you can have a good, fulfilling life with epilepsy. That doesn't mean that your life has to be tainted in any way whatsoever. Now, let's define what epilepsy is. But you're going to start thinking, who's going to define epilepsy for me? You might note, when I was an undergraduate, we used to have so many different definitions of epilepsy, and no one could get it right. It's not something that we were taught in a very straightforward manner. And there's a reason for that. There's too much literature out there, and different bodies had different things. But now, we have the International League Against Epilepsy. This is the preeminent body that collates lots of epilepsy research, and they meet all the time and they give us different recommendations. So far, as of 2017 was the last Congress that they had, and these are the definitions that we have for epilepsy. So, it's a seizure, it's at least 2 unprovoked or reflex seizures occurring more than 24 hours apart. The next one is 1 unprovoked reflex seizure and a probability of further seizures similar to the general recurrence risk after 2 unprovoked seizures occurring over the next 10 years. That's a really long time. And 3, let's see if it's working. 3 is diagnosis of an epilepsy syndrome. But that seems silly. What do you mean epilepsy syndrome? There are many things like spasmus mutans, which all of you are very aware of. That in itself gives you a diagnosis of epilepsy. But if you keep reading there, we keep talking about epilepsy and not seizures. What's the difference between epilepsy and seizures? So we'll do this in reverse. Instead of me telling you what a seizure is and showing you what the problem is with people's definition of seizures, let's classify it first. So still, according to the International League Against Epilepsy, we have 2 classifications of seizures. So we have one, which is the basic version, which is not for people who deal with the brain primarily. And then we have the other one, which is for you and me, people who deal with the brain every day. So let's start with this. If you give me a second, I can put my pointer. I hope you can see my pointer. Yes, you can see my pointer now. So we have 3 things: focal onset, generalized onset, and unknown onset. So what differentiates focal and generalized onset? Very simple. Whether or not the patient is aware of what is happening or not. If they're aware, it's focal onset. They could have partial or impaired awareness. They know that something is happening. Generalized onset, they rarely know what's happening. You tend to get third-party history. Unknown onset, these are the ones that we tend to see most of the time. We don't know where they came from. We don't know how things happened. The story doesn't seem to be the same, but you highly suspect that they have seizures. And these could be motor or non-motor. And then there could be the unclassified ones. These are the complex ones that we're not sure, but you have to watch to see what happens. So with all of those, they can be, for focal onset, they can become focal to bilateral, tonic-clonic. Now, aside from that, let's put some more meat on these bones. So for everybody else here, we still have the same 3: focal onset, generalized onset, unknown onset. And let's start to populate these with a few more. So patient can be aware or impaired awareness. Motor onset seems like things like automatisms. Remember, automatisms can be very complex movements. The older you get, the more complex things you learn. So you'll have things like bipedal automatism, so people who are sleepwalking. You've had these things of people going to drive, that can happen. Atonic seizures where everything goes flat. Clonic seizures where everything just starts to move all the time. Epileptic spasms, which everybody's aware of. Hyperkinetic spasms, which we all know. Myoclonic jerks, tonic jerks. Then we have non-motor onset. We have things like autonomic seizures, things like erections, sweating, palpitations, behavioral arrest. They just stop being who they are. They change something else. Cognitive, they start thinking differently. Emotional lability, we've had many of these. I believe at Kenya National Hospital we had this girl who completely changed her ways, to say it politely, and it's only her mother who kept going with her, and we found out that she did have, in fact, a large frontal meningioma. We also had another one, a gentleman who had severe depression, refractory to antidepressive medications, and developed seizures, and he had a large frontal meningioma. After that, he didn't need any of those medications, and sensory, which we've spoken about. Then we have generalized onset, and these are the ones this is what people normally think is a seizure. So we have tonic, clonic, all of these, I won't waste time saying them. Typical, atypical, myoclonic, eyelid myoclonia. Then we have unknown, which could be tonic, clonic by the time you see it, epileptic spasms, or just a change in behavior, but you don't know how it started and you don't know what's going on. These might take long to see. And all of those give us a large picture of types of seizures. But wait, we've still not defined what a seizure is, and we have to define what a seizure is. So I want you to watch a small video and you tell me what you think the problem is.
Epilepsy is the most common serious neurological condition affecting millions of people of all ages and races. It is characterized by the presence of recurrent seizures, also referred to as convulsions or fits, due to increased activity of brain cells. The normal brain function is disturbed in epilepsy, resulting in convulsions, involuntary muscle spasms, strange sensations, abnormal behavior, and eventually loss of consciousness. The type of symptoms an individual experiences during an episode of seizure depends on where the seizure begins in the brain and how it spreads.
Good. So that's, I would say that's about 70% correct. But for you as a medical professional who will deal with seizures, there's one big problem that needs to be said. That's not the standard definition of epilepsy. The standard definition of epilepsy is, it's not increased firing. Everybody says increased firing, but it's not. It is disordered cortical firing in an epileptogenic focus. It's disordered or disorganized because it can be increased, decreased, staccato. So there are very many different patterns. And the second most important thing is an epileptogenic focus. That's more important because of us as surgeons, where we come in. The epileptogenic focus can be physiologic, it can be anatomic, it can be structural, it can be due to injury, it can be pathologic. So all of that is what we aim to define, and that's what you should keep in the back of your head. When you hear somebody has a seizure, you have to think why. You need to find the focus. And more so if the person has epilepsy. Now, that's all well and good telling you all of the stories about what's happening and how to define it. But charity begins at home. So what's happening locally? So for this discussion, we're in Kenya, and I'll stick to Kenya. So I did a long literature search, and I found this paper, and it's Epilepsy Diagnosis and Management of Children in Kenya, a review of current literature. So they did most of the hard work for me. So I think they identified about 908 papers to deal with epilepsy from all different cadres, but only about 35 met their strict criteria. From those 35, we got some very, I would say, harsh statistics. The first thing that shocked me is the lifetime risk of children to develop epilepsy in this country in the year of our Lord, 2019, the time this paper came out, was 20 to 41 per thousand. That is ridiculous. 20 to 41 per thousand chance of developing epilepsy. I mean, children will develop epilepsy in their lifetime in the country. I thought that was frankly ridiculous. It goes up to about 200 per 100,000. So what we're saying is that this is unreasonably high. And the other issue that they have is the definition between seizure and epilepsy was lacking between medical professionals and of all cadres. So it was spread up and down. So what we know is that these people are there. Whether or not they're seeking help is something that we're not aware of. The next thing that we went to do, so when I looked and I found if it's that much, is there anybody who's looking to see how many of them are dying? And then I found this paper which came out last year from Kilifi. So the previous paper was done by people at the Aga Khan University Hospital. And now this done at Kilifi, what they did is they checked all the patients that came to them. And for those who are unaware, Kilifi is a coastal town. I wouldn't call it a metropolitan town, but it's a relatively big coastal city. Now, at this hospital, they had about 4,000 unique visitors with epilepsy, and they divided them into two groups, people with epilepsy and people with non-epileptic seizures, and they checked the mortality rate. I think the mortality rate was about 6.3 per 100 for those with epilepsy, the PWEs, versus those without epilepsy, or non-epileptic fits, which is about 2%. Those are still quite high. So if you're interested, you can read these papers. You can see the DOIs here and go and get more information regarding this. You can see the causes of death, etc. But I think the main issues are the same. It's identifying the type of epilepsy, the follow-up of epilepsy, understanding anti-epileptic drugs. What's good is people seem to know how to deal with the status epilepticus and epileptic emergencies initially, but the burden of care starts to get a lot worse the more you deal with people with epilepsy, and the understanding tends to be a bit less. Now let's go. This is where the fun begins, as you can see there. We're going to talk about diagnosis of epilepsy. So let's create a picture. This will be the stereotypical resident. All of you were there. Hopefully some of you are still there. And this is you at about 3 o'clock. You've been called to review someone, and you've been told what I think is the most useless information. You've been told, hey, hello, mtoto ameanguka. That means has fallen for those who don't speak Kiswahili. Now, and that's all you keep being told all the time. Then, depending on the resident, if it's 3 o'clock, you have other things to do. Your consultant has given you things to go and write. You have subjects to read. You might get very stressed. And at some point, the history gets lost. And you just say, child with seizures. Next thing, somebody will write, child with epilepsy. Then they leave it from there, and everybody starts managing the patient. Does this seem familiar? If it does, herein lies the problem. You have to get a pretty good history. So whenever you see anybody and you've been told seizures, you need to just go back to the history. The first thing you have to do is differentiate it from any movement disorder. There are a myriad of movement disorders. Your Merit's Neurology has chapters and chapters on movement disorders, which I advise you to go through. But with this, as we said, seizures have 3 parts. We have the pre-ictal or the aura, the ictus, and the post-ictal. So the pre-ictal normally tells you where the focus is and where it's starting. The ictus tells you how it's spreading. The post-ictal tells you how bad it's spread and the magnitude of the seizure. So when you go, what are the things a couple of things you should look for in the history? So here, you should look for seizure frequency, you should look for sleep activation, look for seizure onset, progression, look about if it's initially motionless, look for automatisms, things like bipedal automatism, which I told you about before, complex postures, motor signs, somatosensory symptoms, speech, seizure duration, secondary generalization, post-ictal confusion, post-ictal dysphagia. All of these would tell you something as simple as whether it's the frontal lobe or the temporal lobe, which are the two most common. But we're neurosurgeons, so you'll mostly be concerned with the temporal lobe. And with that, we look about this. So you think about ictal speech arrest, ictal speech preservation, ictal dysphasia, ictal emeticus, urinary edge, and things like goosebumps. All of these will tell you if it's the dominant or non-dominant hemisphere, and that tells you how you need to manage the patient. And think of it, and remember this, it's because you don't just want to send them home with anti-seizure medication and hope that they get better. So you need to spend time with them, especially once it starts to become refractory. You need to go back to your history. So we go back to this place. So we go back, you see this? No matter how tired you are, if you hear somebody has had seizures, make it casual, make it as normal as possible. Just like having a long craniotomy. The craniotomy doesn't care what you feel about it, you still have to do it. And I'll keep emphasizing history taking. So that's the first thing to diagnosing seizures. Then from there, we go to something that, this is a picture from a German company. It was all over the internet. I believe it was about 2014 or so. I stand to be corrected. This picture was all over. They donated 3 of these machines to Kenya, as they said. One of them was donated to KMTC, which is right across from Kenyatta National Hospital. How many of you know what this is, or how many of you have seen this? You can just type in the site. This is a scalp EEG. Now, if you're going to take anything away from this, take this. EEGs are the gold standard for diagnosing epilepsy, not diagnosing a seizure. Diagnosing a seizure is your history. Diagnosing epilepsy is the EEG. Now, what types of EEGs are there? There are 2. Oh, wait, before we go to what types of EEGs, I forgot about this. This is still from another paper, and I need to show you what the issue is. This is 2019. Now, if by the time they're donating EEGs to KMTC, how many of you work in the districts? How many of you have seen an EEG? And if we're having a lifetime risk of 20 to 40 per 1,000 and about 200 per 100,000, that means that this is widely prevalent. How many of you have seen an EEG in your hospital? And therein lies the problem. I'll read this verbatim. Health facilities in many areas lack specialized hospital equipment crucial for investigation of epilepsy, such as MRIs and EEG equipment. Public healthcare facilities for children with epilepsy in Kenya are particularly limited, and national investment in such infrastructure and efforts to integrate epilepsy care into existing primary healthcare systems is inadequate. It's unfortunate when we were doing PHC, epilepsy was not added because it's a silent thing that no one is seeing. But as you saw from the news report at the beginning of this, people are starting to take note because the public is getting more and more educated. Okay, let's go now to types of EEGs. So there are 2 main general types of EEGs. One is better than the other. So what we've seen are these scalp EEGs where you put numerous electrodes and you measure electric current across the scalp towards all of the different areas, and you'll get multi-channel EEG recordings. EEGs are the easiest thing to read because you have something that's normal, then you'll have a part which is abnormal or not following. Then you just need to go and check and correlate as to which part it is. The one which is better would be these video EEGs. So we haven't reached this yet. I don't know many facilities that can do this. I do know some patients that are able to buy this or do this themselves. So what happens is you have the patient, you put the scalp EEG monitoring equipment. This is done in the hospital setup, and they have continuous video recording. So the continuous video recording takes us back now to that history so that we can see and analyze what type of seizure it is. When you can tell it's happening in the hospital setup, different things can happen. People can come and ask questions, especially if it's a partial seizure, etc. So you can see naturally this is better than this. Remember what I was talking about EEGs? You can see here and here there are problems. All you have to do is just go back and see where was the placement of the electrodes. Do you need to memorize it as a neurosurgeon? No, you have more important things to memorize. Okay, now this is a picture of an actual patient, one of my patients. This is a young boy. If I remember correctly, this is a young boy, about 13, 14, couldn't focus in school, couldn't concentrate, grades went down, was known to have seizures for a long time, but they just kept getting generally worse. He started having things like emotional arrest, forgetfulness. Then they started spreading to generalized tonic-clonic behavior. And by the time he came to see me, I think he was on about 4 anti-seizure drugs. Now, before he came to see me, he had multiple scans. All of them were put as normal. At no point did somebody ask for a seizure protocol. He went to a very good neurologist who asked for a seizure protocol, and then we saw this here. Then he was referred to me. And as we look carefully, I labeled it for you. You can look and you can compare both sides. So at the T1, what you'll notice is that one side seems to be slightly smaller. You can see this right here if you compare the architecture. The next thing on the T2, you see that this place starts to light up. Now I'll give you 2 seconds if any of you can tell me what this is. This is the commonest reason that neurosurgeons would do surgery for patients with epilepsy. I'll give you 5, 4, 3, 2, 1. It is mesial temporal sclerosis. Yes, I know some of you already knew this, so that's good. Now, before we go allow me to crack a really bad joke. I recently just learned about the 7 princes who became the first oligarchs of Russia. And I just realized we have 7 imaging modalities that we're supposed to do in epilepsy. So these will be the 7 princes of epilepsy surgery. So we have positron emission tomography. And with that, all you look for something that's hypometabolic interictally when there's a seizure. Then you have spectroscopy. Then you look for hypoperfusion interictally. The only other thing with SPECT is you can overlay SPECT, which is a CT, on top of an MRI when it's done at the same time. I'll show you some images. And you have magnetic EEGs, encephalography. These ones you'll see interictal epileptiform discharges. It also allows you to do functional mapping. It also gives you some positives when you don't see them on traditional EEGs. So there's utility. Then we have the WADA test. WADA test is just for localization of functions within the brain. What you do is you pretty much just knock out some parts of the brain and see if the patient is still able to do things, and we'll go through that. WADA test is also really good because it helps predict post-operative decline. So with a bad WADA test, this is not a good candidate for surgery. Unfortunately, there's nobody that does WADA locally at present, even though now we have many endoscopy suites, and we'll see that. fMRIs are available here, just depending on the protocol. You just have to request it, and you can do sensory and language function. And then at the same time, this goes hand in hand. You need to do neurophysiologic testing when you're doing any of these. Okay? Now, what we'll do is, we have these 7 princes of epilepsy surgery. Now, I'm sure all of you are wondering, but doc, do I send them for all of these things in the clinic? And am I taking all of their money? No, it's supposed to be integrated. And now what I'll do is, I'll show you a center that has integrated everything together, and it will walk you through with one patient. All right. Now, before we do that, let's do PET. So this is positron emission tomography. And with that, you can see the brain is lighting up. It's all the way lighting up. But as I said, what happens is it becomes less, let's go back here, you can have a look. It becomes hypometabolic interictally. Sorry for dancing, as they call it. As you can see here, this part is hypometabolic. So just like that boy right there, this part, which seems to be the middle temporal lobe, mesial temporal sclerosis, seems to be hypometabolic. It's blue during the seizure. Now, this is to show you, when I started, there were no PET scans within the country. This is 2018. This is after I graduated. Aga Khan University Hospital launches the first PET CT. So if you really want to find out, you can send your patients there to find out. But wait, this is a private facility, and most of us seem to work in government facilities. Yes, this is the cyclotron. That's the machine that does PET scans at KU Teaching Hospital, Kenyatta University Teaching and Referral Hospital. You can see it's a state-of-the-art cyclotron, even better than the one at the Aga Khan. So we do have a public option and a private option for PET CTs. So start doing them so you can start learning how when they're useful. All right. This is an overlay of SPECT. So if any of you are looking at this, you're wondering what image this is. So this is a SPECT, which has been overlaid on top of an MRI. And this one becomes hypermetabolic interictally. So as you can see there, the same thing, the medial temporal lobe, which is smaller, is really lighting up. But you can see this one is spreading to also go to the lateral temporal lobe. So this patient would have both medial and lateral temporal lobe signs. Right, this is the one I've never seen. It looks like a very nice machine, but the nicer the machine looks, the more expensive it is. So this is an MEG, and if you can look at it, you see that this one isn't localizing at any point. And see, what it does, it gives you like an MRI, and down here, it also gives you our beautiful, nice recordings. So this one seems to be a diffuse. This is just a picture I got off the internet. It's not of the same patient. All right. Now, this is what I was telling you about, how we have to integrate all of the investigations together. So this was done in New York. This is a retired fire lieutenant who suffered from, I hate the way they say brain bleeds, who had a hemorrhagic stroke and cerebral edema in 2016. And then they were suspicious that he had other underlying causes. What they mean is AVM. Remember, AVMs are one of the things that can cause sorry, I'm getting tired. That can cause seizures or epilepsy. So they decided to do water test. I want you to pay keen attention to how they integrate all the tests together.
We did the CAT scanner, and the rest I don't have a lot of memory of.
Well, he came in specifically for a procedure to determine what side of the brain his memory was localized to, called the WADA procedure.
So what is the purpose of WADA test is, as we know, the left brain leads the right side of the body from motor-wise, movement-wise. The right brain leads the left side of the body. But in regard to language and memory, it is not very clear-cut cookie.
I oversaw the EEG and I did the clinical exam. Basically, the EEG is to look at his baseline brain electrical activity. We characterize it prior to the injections of the medication.
Catheter goes up to your groin, and they administer a short-acting anesthetic.
FDG.
Knocks out parts of your brain.
During that time when the injections are made, we're using the EEG to determine whether the brain has been completely suppressed or put to sleep. For his case, the neuropsychological component of the testing is probably the most important part, because it's testing his visual memory, his verbal memory. It's trying to figure out what side of the brain the memory is localizing to.
If we go to the right carotid, we ask the patient to hold the left arm up. So once we see that the arm is falling down and the EEG showing the suppression of the brain activities, we know that this brain is numbed. And once the strength comes back and the EEG comes back, we know that that's the time that his brain is back to normal, and again reevaluate the patient.
I think this is important in his case specifically, is to determine if he needs to go for a biopsy, what side of the brain would be more.
Okay, so now I want you to pay attention and see what happened. You notice it's not the neurosurgeon doing everything by itself. I know you couldn't tell, but there's a neurologist there, there's a neurosurgeon there, there's an endovascular surgeon there. But at least this time, the neurosurgeon was also the endovascular surgeon. There's also the neurophysiologist who was also there, and the radiologist. So that's already a multidisciplinary team of 4 people just to manage just one patient. And that's where we should be moving. Okay, and now, like, so some of you, I can hear behind your screens already saying, okay, that's well and good, but doc, why do I need all of these tests? I can just give him this furniture and go home. And then if I get a tumor, I can operate. But you're missing some of the points. There's one reason why we do all of these tests, and you need to escalate as appropriate. EEG would be bare minimum. And the reason we do all of these tests is simple general principle that you need to remember for any time anybody asks you about operations for epilepsy. It's this. You need to ask them, where's our epileptogenic focus? That's the main point of this. So I'll read verbatim. The goal of pre-surgical evaluation is to determine if the patient has a single epileptogenic focus that is not in eloquent cortex and can therefore be resected without causing an unacceptable neurologic deficit. That's the main reason. This last one there was just to re-emphasize that we miss a lot of these cases. Is the most common location of seizure onset in adults and patients is the temporal lobe, especially the medial temporal lobe, the hippocampus. And that's also the location that's most amenable to surgical cure. So you're missing them. If you've not done one before you've graduated, you're not looking at them. Look at your seizure patients properly. Now, let's go to the surgical procedures, and this gets really exciting. I need one addendum. To do this justice, two addendums. To do this justice, we would need to literally pick one procedure and discuss it at depth. But more importantly is for you to realize why you're doing it. The second addendum is, if you actually think about the procedures, they are very easy to do, but you have to have very concrete anatomical understanding. Sorry. Once you have good anatomic understanding, doing most of these procedures are going to be very, very simple. So once you have good safe hands and good technique, you can do any of these procedures. And what are these procedures? So they're put into three main procedure types. We've talked all about the surgical focus. That's the whole reason we even get involved. So one is, you can do something to help identify the seizure focus with your knife. You can do what most of you are thinking, to remove the seizure focus. And then the other thing you can do is you can do something where the seizure focus is way too large for you to do anything, or it's right next to eloquent cortex. So what are these things that you do? We do diagnostic surgery. I find it such a funny thing to say, diagnostic surgery. The other thing we do is curative surgery, which is what all of us want to do all the time. And the last one is we do neurostimulative and palliative procedures. You can already see, working within the local industry, all we do is focus on curative procedures. We're missing diagnostic procedures and neurostimulative procedures. Once in a while, I might see some diagnostic procedures and neurostimulative and palliative procedures for epilepsy, but they're not the norm. Okay, so let's go to diagnostic procedures. First time I heard about this, I thought it was so complex, and only to laugh at myself and realize it's actually not complex. Though you, as they say at the University of Nairobi, you have to have meticulous attention to detail. So what you do is, you get a brain grid or subdural electrodes. I'll show you just a flat sheet, which is labeled, not unlike our EEG labels. And this is because the current to go from the brain all through all of those layers to the skull, sometimes you can't identify or localize or pinpoint. So sometimes you'll have a general area, which could be, it's coming from this hemisphere, and you want to find out where from this hemisphere would it be safe to resect. So then you go and do this. So what you go and do is you just do a formal craniotomy. Once you do a formal craniotomy and you remove the bone, you put this little brain grid and you just connect it to the electrodes. I think I have a better picture. Yes, there you go. And this is how it looks from the top. And just like before, everything is labeled. So you have to have meticulous attention to detail, know where everything is. You have to be very aware of where your anatomy is. And with this, you will map the brain and know where the seizure is coming from. So let's say you'll say seizure is coming from, it starts at 13, going to 5. You'll know you'll resect this area right here. But how would you know where it's going? You're right. After you do the formal craniotomy, you put everything back, and then you send the patient to an epilepsy center or neuromonitoring center. And there they'll do all the things that we did. The video EEGs, the continuous monitoring, and you identify, yes, this is the actual point where it happens. You don't send them home. So you see, we can't do this procedure unless we have an epilepsy center. So this is just showing you how it looks. So this is a patient who did a large hemicraniotomy. You can see the frontal lobe, the parietal lobe, the Rolandic fissure, the temporal lobe, the occipital lobe, done nicely and beautifully, but you can see they bled a lot. Just joking. Then, as you can see, they put multiple grids here. This is why you have to have meticulous attention to detail. It's not something that you're hurrying to do. The fun thing is it's not an emergency. You're planning when to do this. And you can see they don't think this one is coming from the temporal lobe at all. So they've left the temporal lobe completely because they got a good history. They probably have an EEG as well, so they know where to focus on. When you put everything back, this is how it looks when you do your CT scan. You can see on the bone window. And what you have in some facilities, you can map like this, 3D mapping, so that you can see where everything is coming from. And then from there, you'll know where you will be planning to resect. Okay. But I'm sure some of you are thinking, but doc, not everything is going to be superficial. Right? If it was, life would be very easy. Sometimes things are going to be very deep. And you know we don't like going for deep things blindly. So with that, we use depth electrodes and we do something called SEEG, stereotactic electroencephalogram. This is, I'll show you the picture, then I'll show you how you do it. So with this, we get those really deep probes, and you put them in specifically targeted areas that you suspect things are coming from. So these are not for superficial things. But I'm sure if you stop, let's stop and think very practically as neurosurgeons. Some of you are thinking the same thing. Doctor, I could get lost. It could be super deep. My trajectory might change. But I'm not too comfortable putting this deep thing. I might go and knock off something. And you're correct. So how do you think they're done? We don't do them blindly. So what you need to do is you need to use some form of stereotaxy or neuronavigation. Most of the time people use framed stereotaxy. And for framed stereotaxy, you have the frame which has been measured. And with that, you know that there's no risk of movement. The only problem with framed stereotaxy is the measurements have to be very correct. And you'll get something that looks like this. So you would still go to theater and you'd put 1, 2, 3, 4. Fortunately, I didn't get a picture of the frame. This was a frameless stereotaxy that was used. And I'll show you some pictures of frameless stereotaxy. The other thing that more advanced centers use is, they use this. If any of you have seen this before, some of you have worked with this. This is a robotic arm. So I don't know which one this looks like. It's called a ROSA. This is a ROSA robotic arm. So what happens is the robot has been programmed with things as the trajectory, and all the surgeon does is goes to where the robot is holding and pushes it in, and you label everything. I hope you see the main thing about this is labeling and following up. After this, you send them to the epilepsy center, which should be in the hospital. But things are not that bleak. We already have frameless stereotaxy. At least within 2 hospitals in Nairobi, we have frameless stereotaxy, otherwise known as cranial neuronavigation. As you can see here, with an MRI overlaid on top, and with this pen here, you do registration. So the pen has gone through all of these parts. So with this, you can identify some of the deep foci, but you have to be meticulous. The patient cannot move. If the patient moves, you can see that you can get into the wrong trajectory. So it's not the type of thing that you allow residents to come and touch the head and move the head. This is a very nice, delicate procedure. But the good news is it's possible, and we're moving there. Okay, I've already talked about this. So with diagnostic surgery, it's just the first part. It's not the end. And diagnostic surgery, you do the diagnostic surgery, you have to go to an epilepsy unit, preferably in the same institution. Then from there, you make a decision as to do curative or palliative surgery, or even no surgery at all. So let's go to the non-diagnostic procedures. I know this is where all of the surgeons have been waiting. I can see your hands have been shaking with bated breath, shaking kind of like that. So let's go through them. Let's start with the resections. These are super easy to do, as long as you know the anatomy. And these are the formal ones that you do. Anterior temporal lobectomy. So many of you have done that in trauma theater. Hopefully a formal one. Lesionectomy. All of you who have resected a tumor have done that. Neocortical resection. All of you have done that. Hemispherectomy. You have not done that, and we'll talk more about hemispherectomy later. Then you have the other ones, which is what most of you thought would be the surgeries we talk about. Things like corpus callosotomy, multiple subpial transections. I call that just the little sauce that you add on top. And then the ones where we're going, I would like to do these personally because they're very easy to do and straightforward. Would be, okay, maybe not deep brain stimulation. So deep brain stimulation, vagus nerve stimulation, responsive neurostimulation looks very high-tech. It looks very fun to do. I don't know why we don't do it here. This is also long, low-hanging fruit, though it seems like the implants would be expensive. So let's talk about anterior temporal lobe resection. So this is a section to include the amygdala and hippocampus because they're believed to spread and intensify seizures. The indications are 3 main indications, not trauma. The 3 main indications are medial temporal lobe sclerosis, the commonest reason we're called in to operate for seizures, stroke, and then recurrent tumors. Now, the outcomes with that normally include people tend to be seizure-free, depending on the series, 34 to 74%. The most frequent complication you can remember, which is why for the 3rd years we always ask you to talk about the visual fields, will be a visual defect occurring from the temporal lobe resection if you go through Meyer's loop. And this is how it looks. So if you look carefully here, this patient, this is the tip of the temporal lobe. and we're coming round here. The standard one is about 7 centimeters from the tip of the temporal lobe, and then you go down. It's nothing too complex. All you do is you just coagulate and suck, coagulate and suck. If it's in the dominant hemisphere, it's about 5 centimeters, and you have to decide if you're going to spare the superior temporal gyrus or not in the non-dominant hemisphere. There you go, very simple, straightforward procedure. There's no point me going through the steps. This is another one. This is the one that all of you have done. If you've done any intraaxial temporal lobe lesion, this is what people equate to epilepsy surgery. This is also another patient this is a patient from Kenyatta. The previous one was a private patient. This is just craniotomy for any lesion. Let's go through this. As you can see, so this is exactly what you think it is. This is a patient at the Kenyatta Hospital who had a large metastatic lesion with neurovascularization that you can see there. So the main indications are medial temporal lobe sclerosis, stroke, AVMs, and tumors. We always do this for tumors. You get seizure-free in 2 out of 3 patients from most series. That's about 66%. Now, in the best centers, we do brain mapping, which is pretty much what we've just said. All of the investigations that we do for epilepsy are to map the brain so that you know the extent of the resection. If not, you just stay 1 centimeter around the lesion. Next, we have this hemispherectomy. This is rarely done. This falls into the domain mostly of pediatric neurosurgery. So it's either partial or complete resection of the hemisphere. But it's not removing the hemisphere itself. We hardly do that anymore. We've moved more to functional hemispherectomy. And functional hemispherectomy means disconnection of parts of the brain. So you have to do formal disconnection of all of the parts of the brain. The indications are here. We have congenital hemiplegic strokes, hemispheric syndrome such as Sturge-Weber. Both of these we do see at our facility, but we don't seem to manage. Hemimegalencephaly, which we rarely see. And then extensive unilateral cortical dysplasia with severe hemiparesis. The indication for this, it doesn't seem to yield that much benefit. But with these other 3, they tend to have marked resolution. What are the outcomes? So it stops progressive neurologic decline, especially seen in infantile epilepsy syndromes. About 75% of them end up being seizure-free, which is amazing. But you can get things like hydrocephalus, superficial cerebral hemosiderosis, post-op cerebral edema, postoperative infarcts, especially if you ligate the wrong vessels, and of course sinus thrombosis. So these are significant risks. So it's not something that you should try without knowing. This is a video that I got off the internet showing a functional hemispherectomy that you can see there. If you're keen, you can see that this is the insula that they are starting to disconnect. You can see the way he's very targeted in his disconnection of the insula before he removes everything. This is the insula, so this is the last part of the temporal that's going to go. Remember, the amygdala and hippocampus are what are expected to spread seizure, or what are suspected to spread seizure activity. So let's just let it go through until you can see them resected. There you go. And there it is. It's gone right there. You can see all that has gone. Temporal lobe, insula has gone. You can see the floor right there. Right. This is the other one that I just called the salt. The thing that you can add into other procedures if you want to be fancy. So this one you just transect horizontal connections between cortical neurons responsible for the epileptic discharges. You can't do this unless you have very good mapping. This leaves vertical connections intact without significantly impairing the functional capacity. So the indications are things like, let's start with the common things, refractory epilepsy. And then if you have an epileptogenic zone that is located in or near eloquent cortex, then you can do multiple subvial transections. Then there's something called Landau-Kleffner syndrome, which I'll leave you to read. But the outcomes are not so exciting, so that's why it's not that widely done unless it's added to something. So it reduces the seizure rate about 1 in 2, and only 42% of patients are known to be seizure-free. It can be performed alone or in combination with other procedures. Now, the same thing can happen. You can get postoperative neurologic deficits. The ones that have been reported are facial paralysis, visual field defects, and slight hemiparesis. But because of the type of surgery it is itself, these tend to be transient and they tend to resolve about 6 weeks after surgery. I love the number 6 in neurosurgery. And this is what happens. So with the subpile knife, you just make a small hole, and all you do is you just make those nice little cuts and sweeps just around the focus itself. As you just keep going around the focus itself, keep making those sweeps as you cut with your subpile knife. You can see that there. It's very simple targeted surgery. So it can be done together with a lesionectomy if you know that it's spreading from somewhere else, if you've got a good history. So that's why I call that real nice salt with your subpile knife. Okay, but what are the alternatives to surgery? Now these I won't speak too much about because these are the things that I would write and refer for, and you can read about them, but I'll just take you through what they are. So we have laser interstitial thermal therapy. This is the same thing that can be used for glioblastomas, etc. This would be done by a radio-oncologist, not by me. So with that, I won't speak on authority with it. This is a picture of somebody doing laser interstitial thermal therapy for what is a glioblastoma that was causing seizures. You can see this one is very deep-seated. I wouldn't go for surgery for this, send them for laser interstitial thermal therapy. The next thing you have is stereotactic radiosurgery. We're not here yet, but we are getting there. The more utilities we know for stereotactic radiosurgery, now we've added seizures, the more we can request for it. And this is a big one because if it's, I'll repeat that number, if it's 40 per 1,000 in a population of 55 million, you have a lot of work out there. That's lifetime risk. This is the one that I would like to do. This is deep brain stimulation. So with deep brain stimulation, you stimulate direct deep centers using multiple devices and electrodes. It's a long procedure because it takes lots of brain mapping. But think of it not like our depth electrodes, but you connect it to something which will keep giving you electrical discharges. It may also have a sensor to say when there's disordered firing. There are many utilities for deep brain stimulation, and patients love it. They love it especially because they are in control of it. For things like Parkinson's, etc., they press and everything goes back to normal. This is another one, vagus nerve stimulation, almost the same thing with a few indications. This is not something that we do, but this is a procedure that you can go and learn. Well, not unlike deep brain stimulation, but this one, the generator would be put under the chest. This is funny because I was speaking to the junior residents. This is another reason why you have to pay attention to your anatomy in first year and second year. You can't start reading your anatomy of the chest when you're a consultant. It makes no sense. And this is what I said looks very fancy. So you have responsive neurostimulation. This is almost like deep brain stimulation, but now this one has the sensor itself. So it picks up the charges and it either ablates them or stops them. So it has a sensor unit and it has an effector unit. And so it's like, this is what Elon Musk was trying to do when they were saying, put things under our brain. So people already do this here. This is why I said this is fun to do. But you already see you need a craniotome, you need lots of screws, you can see you need lots of equipment here, and the follow-up for this patient needs to be significant. If you pay attention, you also see this is a stereotactic frame, so this is not being done blind. This would be a very long procedure, but it looks like it would be a fun, rewarding procedure. All right, and now the way forward. Where do we go from here? The future is calling. We can't stay in the same place that we were all the time. Somebody has to keep moving forward. So the first thing that you've noticed, the neurosurgeon is not alone. We're not the head of this. We're just part of this. So a multidisciplinary team is needed. So what you need to start doing, even if you start working by yourself and you go to your different hospitals, you need to start identifying individuals with interests so that you can start having discussions to keep moving it forward. So the neurosurgeon will just be there and offer options. So you need to have, we've not yet reached epileptogenesis here. We still have a few neurologists, even though we have neurology training programs now and the number is increasing. So we'll need to start working with neurologists, neurophysiologists, psychiatrists, and neurophysiologists. No, neurorehabilitative physiotherapists. There we go. That's the one I was looking for. And apart from that, we need to do this, which is called organization and integration of care services. So this is the problem. We need to have feedback between the community and the healthcare system, which allows the patient and the family to get education and to seek care. Because imagine being told all of this and you're not a medical professional. You'll think everything is extra, or somebody's trying to get things away from you. And imagine the way it is right now. You have to go to multiple different facilities for what you call basic things. Imagine sending somebody all the way to Kenyatta National Hospital to do an EEG. It makes no sense. Once they get the EEG, next you have to send them to look for a neurosurgeon. These are all the problems that we have, and this is why we tend to lose patients. For all the residents who don't have any questions, this will be a good question locally to see what happens to any of our patients, to even find out how many patients have surgically amenable epilepsy at the epilepsy clinic, which is run by the internal medicine department. That's one good one. 2 is find at which point they would get lost with care, or find out what difficulties they face in accessing epilepsy care. Is it cost of drugs? Is it availability of drugs? Availability of personnel? Is it that they get conflicting information from medical officers, neurologists, neurosurgeons? That's a very nice question, and that would go very far. Then when would the neurosurgeon be involved? So I was discussing this with one of my friends, Dr. Beverly Cheserem, and I saw she had this, so I took this word for word from one of her slides, with her permission, of course. When something's not broke, you don't need to fix it. So, is there a focal lesion matched with EEG findings? Then you get involved. Is there a temporal lobe lesion? Then you get involved. Has medical compliance been proven and it's still not working? Then you get involved. Is the epilepsy refractory? We already said that. You get involved. What are the team's technical capabilities? What can you do? If you're not comfortable with a hemispherectomy, you have no business doing it. If you're not very aware of all of the connections between both hemispheres, you have no business doing it, because it can be detrimental to a child's life. Is there access to video telemetry, which is what we saw, the video EEGs, or modern adjuncts? Modern adjuncts now, I forget the name of it off the top of my head, but there's an app now that you can download that gives you video telemetry. So with a phone, what you do is you can record, you place it somewhere or connect to a camera, and what it does, it can connect to any scalp monitoring device or electrode, and you get video telemetry or video EEG, and that you can do from home. Then timing of surgery, you need to think the burden of wellness. This is simple. Just because you can do something doesn't mean that you have to do something. So you have to think about how useful is it to the patient. What are you offering? Because are you helping the patient get better, or are you just doing something for yourself? So you have to think about the timing of surgery, and the best thing about this is it's not your decision alone. It should be in a multidisciplinary team. Now, this is one thing that I think every neurosurgeon gets tired of saying. Surgery is not the end of the journey. Living in a LMIC, everybody thinks surgery is the end, because everyone is scared. They've raised money and they think when they're going for this, it's this. So it is not the end of the journey. Surgery is just something that we add in epilepsy management. Sometimes it's the end of the journey if we're blessed doing something like a lesionectomy and 66% of them will get better, then we're okay. But most of the time, it's not the end of the journey. The other thing that tends to happen is we tend not to wean off anti-epileptic drugs. So we're not able to assess. So this is just a simple slide of the other thing I see is everybody uses the same 3 anti-epileptic drugs for some reason when there are all of these that are available. And we don't get histories whether or not they're generalized or focal seizures. So take a screenshot of this if you're unaware, and just remember what you look for and when to use it. The last part is, with all of these holes, who is going to tell government? Who are the people working in this field? It's you and I. So we need professional advocacy. So there's going to be small scale activities we can do, which can spread the word in large scale. So the small scale things are, we need to drive for new facilities and investigations. We had 2 PETs. The PETs are there. Use them. It's as simple as that. If you remember, NHIF said they will no longer be paying for people to do PET scans outside the country. They don't need to. There are 2 of them here. Next, you need to increase your technical know-how. Read about it yourself. Go for short courses. Do things yourself. The last one, wherever you go, any patient with a seizure, you need to start multidisciplinary seizure clinics to meet unmet need. The patients are there, but they're getting lost in the system. And that's what the research has shown. Now, large-scale things which will outlive all of you would be, number 1, definition of disability. Different countries have different definitions of seizures as a disability. Some of you may or may not be aware. One thing I found out from one of my patients, there's a scam where patients go to get disability cards by saying that they're epileptic, because there are multiple benefits from getting these disability cards. One of the funniest ones I heard is you can buy any motor vehicle without tax as long as you have a disability card. So there's a whole scam which I was completely unaware of, but they go down to the lower level, taking advantage of the fact that they're fewer neurosurgeons. So you'll get clinical officers and people who don't know what epilepsy is writing all of these things. That has to be changed. So we need to define what disability is. Next, we don't have any regional return to work formula. So what do we say? When do we say somebody is okay to return to work? If a pilot has one seizure in Kenya, can they go back to work? That's something that as you keep getting older, you'll start being called in for your professional opinion. And it'll be hard for you to decide, but it's easier to decide with a big group like EANS if we sit and we have little mandates and little things that we write. Next, we need multi-sectorial buy-in. You've seen management of epilepsy is not just one person. The neurosurgeon is one thing. Next, you need to have equipment. You need to have stereotactic frames. You need to have available drugs. You need to have EEGs. All of these need different sectors to come in. But the sectors can't come in if they don't know that they need to do that. The next thing that's needed is if there are all of these seizures everyone keeps reporting lots of seizures. One, are they actually real seizures? How do we know? We need to have a seizure registry. So you need to start either hospital-based seizure registries and move all the way to to national seizure registries. Those are large-scale things that will completely change everything. If we find out that we tend to have a lot of focal seizures, then we can go approach different drug companies saying, hey, we need these drugs in our country to be subsidized because you will get money. All of that is driven by us, and that's what we have to do. Now, let's go back to the patient. What is success? Success is if a patient is seizure-free. That rarely happens. We normally look for seizure control. Seizure control is at least 1 to 2 every 3 months. Then you say that's well-controlled seizures. Improvement in mood disorders. This is one part that's overlooked, and this is why I said psychiatrists are part of this. If even you, as a neurosurgeon, if you had seizures, even one seizure, you're not going to be the same. You're going to be scared. You'll have anxiety. You could get depression. If the seizure keeps happening again and you think you're living like this, you don't think that you're normal, that's a big issue. Next, improved pharmacotherapy response. That one is clear with fewer side effects. Social reintegration, that's the most important thing. What's the point of having life if you can't live? So allow your patients to live. Their limited surgical mobility is good success. There's no point doing your huge craniotomy to put your brain map or your subdural electrodes, and then you give them a huge SSI, then they get osteomyelitis. You've done nothing to help the patient. Then things like oncotherapy and histologic diagnosis, that one we don't know. That's next there. We're going to that next. To immunotherapy options, and above all else, we need to manage expectations of the patient. Now, if you can't remember all of that, this is what success looks like. Somebody living a good, maybe not with the dreadlocks and the tattoos, but somebody living a good, healthy, productive life with hardly anybody realizing that they have epilepsy. There you go. Then again for the older people. All right. So in summary, you have 4 take-home points. You can write these down. The only things I would want you to write down. So, number 1, we have multiple surgical options for selected patients. Next, there are many typos in this last one. Next, we need regional epilepsy MDTs. That's what we need to start. Then, there are huge regional gaps in patient pathways. And we need to develop functional neurosurgery within the country and epilepsy super referral centers. If we can even do just the last one, then we'll be miles ahead of the region. And that would be it. So thank you for your attention. I hope you found this useful. If you are interested, you can get my most recent book, which is on Amazon Kindle and Apple Books. If you have any questions, you can get me here. If you want my complete list of references, you can also email me here and I'll send it to you. Thank you for your attention. I'll now welcome any questions. Thank you and good day.